Okay, Bismillahirrahmanirrahim. So today I will try to discuss some like topics from here and there important for hematology, which is remaining, and also main part is our oncology part. Okay, our oncology is very important. Okay, and one very important thing that people are getting confused, that myelodysplasia, that myelofibrosis, the differences and how we will diagnose this. Okay, so that one is the important one. So we will go one by one. Okay, so let's start, inshallah. So Bismillahirrahmanirrahim. First, today I want to discuss you about hereditary, hemorrhagic, telangiectasia. This topic is very important. Okay, so why this topic is under hematology, I want to discuss, because this hemorrhage, this is not because of platelet. This is actually as a genetic disease. Okay, I told you before that if you see the word hereditary, the word, this is always with AD, autosomal dominant. Whenever with any disease, the name is hereditary is there. Blindly, even if you don't remember, then this is autosomal dominant. Okay, dear? The word hereditary, it is usually with the autosomal dominant disease. So this is a autosomal dominant disease. Okay. So what happened here? First, let's understand the physiology, that how it happened. So what happened? This is our normal blood vessel system, this one. Normal blood vessel system. So what is this? This red one is our artery. This is our artery. And this is the vein. So from heart, the blood is going to the arteries. And from that arteriole, ultimately it will form the capillary. Okay. So from vein, what happened? The blood is going to the heart, right? So these are the vein. So from vein, it comes the smaller branch, that is venule. After all, it will form the capillaries. So this is like a capillary. So this is the whole what? Capillary blood vessel system of our body. This is normal. This is normal. What happened in this disease? In this disease specifically, this capillary system, it is not formed, or maybe abnormally formed. Okay, there is dysplasia of this whole system. Okay, so the capillaries are not formed in a very good way. So what happened actually, there is like connection directly from the artery to the vein. From the artery to the vein, like connection. This is known as AVM, or arteriovenous malformation. Okay, so this is the AVM system, that because of genetic causes, this capillary system.
For severe cases of steroids.
Yeah, that's anything. Okay, no, someone was telling something about it. So the capillary system will not be there in a full form. So what happened? The arteries are directly connected to the venous and forming this arteriovenous malformation. So what happened when there is, like, this is not normal, right? So it is like the bonding will not be that much strong. So anytime from this malformation can happen the bleeding. So in this case, there is chance of hemorrhage, there is chance of bleeding. It could be from nose, it could be in the GI tract, it could be in the hepatic area, I mean inside the liver, it could be in the spine. So anywhere of the body, wherever there is AVM, arteriovenous malformation, they can form anywhere in the body. Ultimately, what happened? Then they are doing this arteriovenous malformation, and ultimately hemorrhage is there. Okay, so this is the pathophysiology, how this happened. Now come how you will diagnose. How you will diagnose. Okay, the diagnosis is that there are 4 characteristics. Okay, there are 4 characteristics. So tell me, hereditary, hemorrhagic, telangiectasia, right? Three words are there. So if there is, that's how I am remembering. Okay, so if like there is 3 character or more than 3, so is equal to or more than 3, if it is like that, then this is definitive diagnosis. But if it is only 2 diagnostic criteria meet up, then this is maybe the possible. So this is important that you need to know this 2, 3, 4. I mean, there are 4 main characteristics. I'm coming to that. What are the 4? Within this 4, if 3, I mean 3, the words are 3 in that name, right? So that's how you can remember that if 3 criteria are met, it is definitive. If 2 criteria, then this could be a possible hereditary hemorrhagic telangiectasia. Okay. Now come, what are the 4 criteria? These 4 criteria, what are these? So again, come to the name, hereditary hemorrhagic telangiectasia. Hereditary means what? Hereditary means this could be genetic. So what is the genetic? I told you from the hereditary, it should be what? It should be autosomal dominant. So the first point is there should be a first degree relative, at least one person who is having maybe father or mother. So any first degree relative, any sibling with hemorrhagic hereditary telangiectasia. Okay, so this is our first point. Now come with another one. There is telangiectasia, right? So telangiectasia, this is our number 2 point. From the name I'm coming so that you will not be forgot about this one, telangiectasia. What is telangiectasia? Telangiectasia means whenever you see in the skin, there is like small widened vessels. Like the vessels are there, it's like red and widened. You can see under the skin or in the submucosa. These are widened, okay? It's not like bleeding, but you can see that the vessels are prominent. Who are very fair, usually who are very fair, you can see also for them some telangiectasia. Okay, so usually this is abnormal. When it is abnormally prominent, like a small and widened, that is telangiectasia. So you will get telangiectasia. This is number 2 point. Number 3 from hemorrhage. So 3 word. I'm just doing the postmortem of this whole name. Okay, so from this hemorrhage, remember the other 2 point. What are these? There is hemorrhage. That means bleeding. The bleeding could be from nose. So there could be nasal bleeding. What is the name of nasal bleeding? Epistaxis. So there could be epistaxis. Or maybe there could be some visceral lesions. As I told you, it could be from anywhere of the body, it could be bleeding. So even if that AVM is in the GI tract, it could be GIT bleeding, right? It is if it is the hepatic AVM, there could be pain in the hepatic area, spinal AVM, it could be there, cerebral AVM, there would be maybe TIA or stroke-like feature. Okay, dear? So these all things under this 3 and 4. So along this 4, if I told you that if 3 points are met, then this is your definitive hereditary hemorrhagic telangiectasia. If 2 point, then this is the possible HHT. Okay, this is our HHT. Any confusion? Any confusion, dear?
No, ma'am.
Okay, thank you, dear. So now come with our next thing that is very important, that people are getting very confused: myelofibrosis, myelodysplasia. Myelofibrosis and myelodysplasia. So let me go to my okay. Now come with the topic myelodysplasia. Okay, myelodysplasia. I'm always postmortem. I mean, dissecting the name, the main name. Okay, because you need to understand the basic in a very good way. Otherwise, you cannot answer any question. Okay, dear. So come with the word myelodysplasia. What is myelo? Myelo means this is the bone marrow. There is 2 lineage. One is myeloid lineage, and other one is, let me write. Other one is lymphoid, right? Sorry. Where it's gone. Okay. So other one is lymphoid. Okay, let me try to write over it. can't I write? I think I should. Okay, anyway, cannot. So the fact is that there is myelodysplasia. The myelo means what? That myeloid lineage of bone marrow, right? So better I would go with my, I think I should go with my, yeah, here I can write. Just a minute. I want to write about this. Okay, I think now I can write. Okay, now come to the point. So myelodysplasia, we will dissect the word myelo and dysplasia. What is myelo? Myelo means there would be the problem with the, I mean, it is the myeloid lineage, myeloid series of the bone marrow. Okay, there is myeloid lineage, and what is that? From hematopoietic stem cell, what happened? Hematopoietic stem cell, one lineage coming like myeloid, one is lymphoid, right? From this lymphoid, B lymphocyte, T lymphocyte, this happened. Okay, and from this myeloid, what happened? All the RBC, WBC, platelet, all are coming from this myelocyte. So the problem will be in this myeloid series, number one. Now come with the dysplasia. What is dysplasia? If there is any abnormal growth, okay? If there is any abnormal growth. So what is abnormal growth, dear? The abnormal growth, I mean, dysplasia, you know, no, right? Dysplasia means there is in a growth, there is abnormality. This is a pathological term, okay? So what happened in this case? From red bone marrow, actually, if this is the bone, here is our red bone marrow in both ends. If it is the other end, here is also red bone marrow. Usually, this hematopoietic stem cells are there, and this one, all this genesis is happening in the red bone marrow mostly, okay? So what happened here in these cases, in this specific disease, the cells in the myeloid series, that means RBC, WBC, platelet, they cannot be adequately matured. They are become like inadequately matured, immature cells. Immature cells are there. Okay, dear? So that is called the myelodysplasia. Okay, so what happened if immature cell, so they are getting died, right? They are getting died. They cannot be mature. Small, like small cells, they are not even before getting mature, they are like dead. They are like dead. Okay, dear. So what happened? The cells, whole cells count, WBC will be low, platelet will be low, RBC will be low. So there will be pancytopenia. There will be pancytopenia because they cannot get mature, and ultimately they're dying in their childhood, if you are telling in like that. So there will be no mature cells, so all cells will be down. So there could be pancytopenia, or maybe any of the cell, it could be down. Maybe WBC only low, or platelet only low, or RBC, or maybe all three of them together low. That means pancytopenia. Okay, dear? Now come, usually which people are having this myelodysplasia? Usually having this myelodysplasia in older people. So if you get the scenery, you will get that they are with older people, 70 to 80 years. Okay, this is one of your question. This is one of your direct question, that myelodysplasia usually common in which age of the people. Okay. Another question is there, what is the median survival rate? Okay, median survival case in case of this myelodysplasia. So myelodysplasia, you can also tell this is MDS, another name, myelodysplastic syndrome. Okay, same thing, because this has actually many stage, many subtypes. So all together, all the types together, these are like we are calling syndromes. It is showing in different syndromes. Sometimes only there is the RBC low, only anemia, WBC low. Like, so there are so many subtypes are there. So that's why this is also called as myelodysplastic syndrome altogether. Okay, dear? So now come, what is this median survival rate? Usually 2 years. So it is a bad one. If somebody with MDS, maybe within 2 years, they could be died. They could be died. Okay, dear? Now, come with, this is like what? Myeloid stem cell disorder, I told you, right? Myeloid stem cell disorder. Myeloid stem cell disorder, we know what? This could be AML or CML. What is the difference between this MDS and AML? Both can have blast cell. As we know, AML is having more blast cell, right? So the difference is that in case of MDS, the blast cell, it should be less than less than 20%. If it is more than 20%, that is already converted to AML. Okay. So what is that thing? This is the same thing. So this MDS, whenever it is crossing the 20%, it becomes AML. So it has a tendency to turn over to AML. Okay, this is one of your questions. That myelodysplasia can turn into which type of leukemia? It can turn into AML. It can turn into AML. The difference is that blast cell here less than 20%. And in case of AML, it will be more than. So whenever it blast cell coming more, we are calling it AML. Okay. So this is our one thing. Okay, dear. Now, come with the diagnosis. Diagnosis, I already told you that there will be what? Pancytopenia. There will be pancytopenia. So there will be pancytopenia, right? I want white color. I love white. Okay. So there would be pancytopenia. Or it could be any of the cells come down, any of the cells. So it could be one or two cells coming down or all coming down. That means all coming down means this is pancytopenia, right? Blast cell, I already told you, you can get it less than 20%, okay? So as they are not getting mature, you will get high MCV. Usually when cells are getting mature, they're shrinking. So immature cell will be bigger. So MCV will be high. MCV will be high. So you will get in the CBC that it could be one cell, two cell low, or maybe all cell line are low. WBC, RBC, and platelet all could be low. Okay, dear? Blast cell less than 20%. High MCV. Then come to the bone marrow. Bone marrow, what you will get? Bone marrow, they will be hypercellular. They are trying to make more because they are dying. So usually it is hypercellular. Okay, dear? And obviously there will be dysplasia. I mean distorted cell. All are abnormal growth. So you will get the dysplasia of all cells. Okay. Here even you can get sideroblast. Sideroblastic anemia. One of the cause is this myelodysplasia. Sideroblastic anemia. So if you find in your question sideroblast is there, and with that blast cell is also there, but less than 20%. Patient is with like pancytopenia, like that. So your diagnosis would be this myelodysplasia. Okay. There is also, it could, there's another name we are telling leukoerythroblastosis. That means all cells are, leuko means WBC, erythro means RBC. So there will be immature WBC and immature RBC. So the main fact is that there will be inadequate maturation of all the cells. Okay, even the RBC, it would be like nucleated RBC or maybe sideroblast. Okay, or immature. WBC also immature, blast cell are more. Okay, just a minute, I need to mute someone. Okay, there was background noise. Okay, dear. So this is our diagnosis. Okay. Now come with our next thing. Okay. So there is how you will differentiate. How you will differentiate from myelofibrosis and this myelodysplasia. Okay. What is, okay, let's finish first our myelodysplasia. with another DDs. This is our slide for the normal slide, right? Like this one I was telling, if in the red bone marrow, there is hematopoietic stem cell, from there 2 lineages there. One is myeloid, one is lymphoid. From the name, you can see lymphoid. So there will be lymphocytes, B lymphocytes, T lymphocytes, and natural killer cell. This is one line. This is one line. You got my point? And this one is the another line. This is another lineage. Okay, so this from myeloid stem cell, RBC, erythrocyte, monocyte, it could be WBC, okay, and also platelet also, there will be coming megakaryocyte, okay. So this is one myeloid stem cell lineage, and this is our lymphoid stem cell lineage, okay. This is the normal one. This is the normal one, okay. So diagnosis already. Not this one. Okay, now come how you will differentiate with other diseases. That is the important thing. That is the important thing. As I told you, myelodysplasia, you can get pancytopenia. So if there is pancytopenia, maybe you will think this is aplastic anemia, right? Right? Aplastic anemia also, we are getting all the cells are coming down. So how you will differentiate? You will differentiate from the bone marrow. Bone marrow, usually I told you this is hypercellular, whereas aplastic anemia, hypocellular, there is not that much production. But here it is hypercellular. Okay, so both can have pancytopenia. The difference is this is hypercellular bone marrow and this is the hypercellular. This is how you can differentiate in your scenario from the aplastic with the MDS, okay, myelodysplastic syndrome. Another DD, it could be myelofibrosis with this. So how you will differentiate this myelofibrosis from MDS, okay? Both can have immature RBC. So it could be reticulocyte nucleated RBC you can find because this is immature, and reticulocyte also you can find this is low, okay? There's not that much production. So what happened, how you will differentiate between this myelofibrosis and MDS, okay? MDS, we know that it is dysplastic. It is dysplasia. That means this is inadequate growth, inadequate maturation. But here what happened, they are having hyperplasia, increasing the number of abnormal megakaryocytes. Okay, dear, which you will not get here. So this is dysplasia and this is hyperplasia. Okay, dear, and also here you can get JAK mutation in myelofibrosis, whereas in MDS you will not find any kind of JAK mutation. That's how you can differentiate this. And also, obviously, if you do bone marrow, you will find findings in here, MDS, bone marrow. But in myelofibrosis, all become fibrous tissue. So this you cannot even take the bone marrow from that because already it is fibrosed. The bone marrow is fibrosed. So you cannot take the bone marrow. This is unobtainable. So you cannot take the bone marrow. That's why that time you have to do the trephine biopsy. You have to do the trephine biopsy. So from bone marrow, easily you can differentiate. Okay, if bone marrow, there is like feature of myelodysplasia, this is myelodysplasia. And in case of myelofibrosis, you cannot do the bone marrow aspiration. So you have to go for trephine